1. تفضل يا دكتورة.
طيب. السلام عليكم ورحمة الله وبركاته، وأسعد الله أوقاتكم بكل خير، وأهلا وسهلا بكم جميعا. Today it is the last and third day of webinar of COVID-19 readiness at King Fahd Specialist Hospital Dammam. We are going to have our last three distinguished speakers, Dr. Mohammed Al-Maghribi, Dr. Mohammed Al-Bishr, and Dr. Yasser Al-Dabbagh, who will talk about different important topics in relation to the pandemic of COVID-19. The first one will be about administrative aspect and contingency plan, then e-learning during COVID-19, and the last will be about mental health and stress during COVID-19. Before I start to introduce our first speaker, I would like to remind all of the audience that we are going to receive the questions at hashtag King Fahd Special Hospital Dammam KFSHD _ COVID-19. So we will start with our first distinguished speaker, Dr. Mohammed Al-Maghribi. Dr. Mohammed Al-Maghribi is an Executive Director and Medical Clinical Affairs Administration of King Fahd Specialist Hospital Dammam and Maternity Children's Hospital. Dr. Al-Maghribi is a consultant pediatric transplant and nephrologist at King Fahd Specialist Hospital, who worked very hard in the contingency plan and preparation of COVID-19 in both hospitals. He is well-known senior nephrologist at the level of national as well as international level. Dr. Maghribi is going to enlighten us and talk about guidance for health system contingency plan. So please, Dr. Mohammed, the floor is yours.
I don't know if the presentation is there. Assalamu alaikum wa rahmatullahi wa barakatuh. Did you see the presentation?
Yes.
If you are following with me with the presentations, I can proceed.
So please, you can proceed, Dr. Mohammed.
طيب بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. I hope that I am not sure that if you are seeing the presentation with me, but it's my pleasure actually to present with you this presentations. I may face a technical problem, sorry for that. Dr. Raida, assalamu alaikum.
Yes, Dr. Mohammed.
Sorry, Dr. Raida. Can Dr. Mohammed Al-Bishr start till I fix my technical problem?
Sure.
I'm sorry for that. Okay.
Sure. So let me introduce Dr. Mohammed Al-Bishr. Dr. Mohammed Al-Bishr is an Executive Director of Academic and Training Affairs Administration, and he is a consultant gastroenterologist and therapeutic endoscopist at King Fahd Specialist Hospital. Dr. Al-Bishr is well-known and senior consultant gastroenterologist who working very hard in academic affairs during the COVID-19 era, and he is going to enlighten us and talk about COVID-19 and e-learning tools. So please, Dr. Mohammed, the floor is yours. Can you unmute your audio, Dr. Mohammed?
unmute. السلام عليكم.
عليكم السلام.
وعليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. دكتور رايد الصوت كلير والسلايدز كلير؟ correct?
Clear, yeah, correct.
Thank you very much. Thank you very much for the introduction. There is no better time and best time to speak about e-learning than the current pandemic situation. There is a significant evolution in the educational technology, and the advancement of technology has really had a significant impact on education. Books and journals have found their way to desktops of students. And the invention of technology have provided a tremendous and easy and quick access to books and journals anytime and anywhere. E-learning, if you look at the last century, or probably the last 100 years, traditional way of learning where traditional classroom where students and teachers are met together face to face hasn't really significantly changed in the last century. However, e-learning nowadays probably gonna act as a complete substitute for traditional face-to-face learning. If we just gonna simplify e-learning, the E in e-learning simply stand for electronic. E-learning is basically a technology, a web, a computer-enabled learning. It's a storehouse of education, information, communication, training, knowledge, and performance management. Sorry. E-learning has developed very fast due to the internet. It has bridged the gap between teacher and student in different ways. Even the computer-based instruction has progressed really fast from the usage of the old-fashioned CDs to the web or net-based instruction. There are a lot of synonyms for e-learning: online learning, distant learning, digital learning, virtual learning. If you talk to the expert in e-learning, they can probably define each of them differently, but more or less they actually represent the same concept. One of the pioneers in education and learning, and in particular e-learning, Bernard Luskin, explains the E. He doesn't want to summarize E as just an electronic. E-learning is not just electronic learning, it's an exciting learning, it's an energetic, it's an enthusiastic, engaging and extended learning. So why e-learning? What's the advantage? Why e-learning is advancing rapidly now? Because simply it's a convenient, it's a self-paced, self-service, on demand, anytime, anywhere. It's considered a private learning, and it's very, very, very flexible. It has a media rich of information and communication that is easily understandable and more engaging. It is repeatable, and it's easier to monitor the progress with really less administrative work, with a better and accurate, precise measurement. It's also probably less costly. Basically, it's consistent. There is a central control of content, same quality of content for all, and same quality for education for all. So basically, e-learning expands opportunity of education, expands quality of learning, increases delivery of learning, and improve efficiency of teaching. There are different way and delivery and tools, whether synchronous or asynchronous. Basically, the difference between the two is in synchronous learning, learning and teaching takes place in real time, same time, but asynchronous learning is when the teacher or the trainer prepare the learning materials before the course takes place, and then the student or the learner can decide when he or she wants to study the course material. There are different tools for e-learning, online forum, web-based or content-based, audio, chat, video conferences, and so on. So just a snapshot on just main differences between traditional and e-learning. If you look at the classroom in traditional learning, it's limited. The physical space is limited. In e-learning, it's infinite. It's unlimited. In traditional classroom, the teaching and the learning is probably always synchronous, where there is always face-to-face, and in a specific certain time. E-learning is anywhere and anytime. If you look at the content in the traditional, it's a textbooks and library at PowerPoint sometimes, and video or collaboration between students. But in e-learning, it's a multimedia and digital library, on demand, anywhere, anytime, synchronous or asynchronous communication. In traditional classroom, there is only one learning path for the learner or for the student. But in e-learning, learning path and pace really determined by the student, him or herself. So it's not easy to build an e-learning culture. For any learning, there are three more common pillars, and e-learner constitute with the same pillars. You have the learner, in which you have to have a self-directed, self-motivated, self-regulating, and lifelong interested learner. And you need to have a teacher or a trainer where he can continuously develop his knowledge and skills to understand the learning needs of his or her students and learners. You have to have a trainer or a teacher who facilitate learning, who create learning opportunities. And at a bigger level or at a higher level, governments or administration of an organization, they need to create a learning environment, a peaceful learning environment that provides a strong IT infrastructures with a lifelong resources for learning. But what makes e-learning a bit different is that there is one important contributor in e-learning, which are the entrepreneurs or the private sectors. We need entrepreneurs in e-learning to create advancement in technology and create user-friendly application, user-friendly platforms and websites, and even virtual reality tools that can make e-learning user-friendly, accessible, and attractive. So for a better and ideal e-learning culture, to have it, you have to ensure that the e-learning is user-friendly. You have to create a learning-friendly environment, and you have to have the support and enthusiasm of top management. In addition, you have to create time for learning, and you have to link for your students or learners or your employee in the organization, you have to link learning to appraisal so that you can promote continuously learning. So just give you a snapshot of an e-learning statistics in the United States published in 2019, where they found that 77% of US companies actually have used e-learning in 2017. And e-learning, they found, is actually an environmental friendly. Figures from an open university suggest that e-learning actually cuts energy consumption by almost 90% and slashes CO2 by more than 85%. So in the era of global warming, this has a major useful implication. For every single dollar spent on e-learning, companies actually make back $30 in productivity. And the e-learning industry has significantly grown to more than 900% since the turn of the century. And around 72% of organizations believe that e-learning puts them at competitive advantage. And around more than 60% of US faculty in colleges and university actually support open educational resources. More than 40% of US college students find digital learning or e-learning technology extremely helpful. And around 50% of them state that they have actually taken at least one online course in the last year. And finally, e-learning enables students to learn actually 5 times more materials for every single hour of training. So when we talk about e-learning, we talk about digital infrastructure, IT infrastructure, digital transformation. So if you look at the global statistics in digital world, there are more than 5 billion unique mobile phone users, constitute of around 70% of the world population, more than 4.5 billion users of internet. And it's expected by 2025, an average connected person anywhere in the world will interact with a connected device nearly 5,000 times per day. Like basically, this is one interaction in every 18 seconds. So if you look at the digital transformation nationally, and where is Saudi Arabia is standing, we have a population of 34 million. Our mobile phone connections is 116% of the population, and around 93% of our population are actually using internet. And this is in a constant growth on a yearly basis. So if you compare 2019 to 2020, there is a significant increase in growth with regard to digital adoption. So in Saudi Arabia, 93% في المملكة of the Saudi citizen actually use, or the population in general, use mobile phone. And 92% of them have actually a smartphone where you can access e-learning easily. Around 60% of the population have one laptop or desktop computer or at home. So if you look at the kingdom in comparison to the rest of the world, our internet penetration, we are actually in the top 10 countries in internet penetration. And we are actually still in the top 10 with regard to time per day spent using the internet. And not only that, we are the average mobile internet connection speeds. We are in the top 10 countries. So for e-learning, you have to have a digital mission. Did Saudi Arabia adopt digital mission? Yes, of course. It's actually digital transformation is part of the country 2030 vision and 2020 national transformation program. If you, probably most of the audience cannot remember, I personally cannot remember when I went to the bank to do a transaction. We use digital technology to do our daily banking, and our government services application has significantly changed the way we live our daily life. Not only government services and banks, but also transportations. In a pool of over than 200 Saudi citizens who are in managerial roles, they all agree that the top 2 sectors that technology should or will impact its development and necessity is actually education and healthcare. And there is no more important proof that the kingdom is actually adopting digital transformation and e-learning than the creation and the establishment of the national e-learning centers in October 2017 upon a royal order. One of the main goal of this center is to govern and organize learning and training, electronic learning and training in the kingdom. Before the COVID-19 era, if you ask anybody about e-learning, whether is it complementary, is it luxury, or is it actually a necessity? Probably most of the answer would be that e-learning is complementary. But when COVID-19, when coronavirus came, when the pandemic of COVID-19 came, I think this has changed the way we appreciate or understand e-learning. Literally in less than 2 weeks, millions of students have lost or couldn't go to their school. Millions of schools have closed their doors. And according to statistics from the UNESCO, more than 191 countrywide closure of school have occurred, affecting 91% of total enrolled learners. So this is really a significant impact on education. Our government suspended education as well. But if you can see in the statement, because of the fact that in the last 3 or 5 years, the kingdom have invested in digital transformation and e-learning, clearly stating here that closure of school should not interrupt learning, and learning and education should continue digitally or virtually. The Ministry of Education created a dedicated website, virtual or vschool.sa, that has multiple virtual and e-learning platforms that help students during their years of public school. Most of the public and private schools in the kingdom and internationally have transformed into a way of virtual classroom. The degree of the transformation or the adoption different from country to country, from sector to sector. But we in the kingdom, we did probably very well in adapting and rapidly transforming our traditional classroom into virtual classroom. Medical field as well. If you look at the amount of webinars or podcasts or broadcasts or even virtual meetings and conferences that address medical information and medical education in general, there was a significant surge in the amount of medical education, both globally and nationally. The Saudi Commission have accredited e-learning platforms, and if you look at the statistics for those, there is a significant surge in the usage in the last month or so during the pandemic COVID-19. And there are the Saudi Commission, who's the licensing authority for medical practice and medical education in the kingdom, have a long and a big e-library platforms and e-learning platforms, provided free access to the trainee in the Saudi training programs, whether in the residency or fellowship, to access these e-learning platforms anywhere and anytime for training and education. And just a simple snapshot of statistics that comes only from the Saudi Commission, a single provider of one of the institutes that can provide medical e-learning materials. They in a 2 weeks time in April, in the first 2 weeks of April, the 2 webinars have been conducted, more than around 60,000 registered, 16 accredited hours, and more than 40,000 participants. The participation, or the most of, like 96 of the participants thought that they were very satisfied with the way these webinars been delivered. Virtual Medical Academy is one of the accredited e-learning platform conducted in a month's time during the COVID-19 era. More than 50 educational activities with more than 235 accredited academic CMEs, with more than 92,000 learners, with 94% satisfaction rate. And this is really with a growth of 400% by 400% in comparison to the COVID-19 era. Most of the medical institutions, including us in the kingdom, have shut down traditional face-to-face academic activities and transformed into virtual academic activities as well. So technology has to integrate with traditional learning. Blended learning is probably the way to go. Mixing traditional learning with e-learning is probably the best approach. So internet has reshaped education. There is no going back. The traditional classroom has to be transformed. Many universities, colleges may not survive in the future. I believe education will not be the same in the post-COVID-19 era. And our 3 days webinar is just a perfect example of how e-learning or digital learning is accessible, affordable, flexible, convenient, and hopefully of meaningful value. I will conclude with this slide. This is the virtual meeting of the boards of the national e-learning centers conducted early this week. I just want to emphasize the statement of the Minister of Education. التعليم عن بعد سيكون خيارا استراتيجيا للمستقبل وليس مجرد بديل. So distant learning or e-learning is a strategic option and not an alternative option. Thank you.
Thank you very much, Dr. Muhammad, for excellent and informative talk about e-learning during COVID. I just would like to remind all of the audience that we are receiving the questions at #KFSHD_COVID-19. Dr. Muhammad al-Maghribi, are you ready now? Assalamu alaikum. You are muted, Dr. Muhammad. Assalamu alaikum, Dr. Muhammad. We will leave the questions at the end of the talks. Will be discussion.
السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله. We see your slides, Dr. Muhammad al-Maghribi. We just introduced Dr. Muhammad al-Maghribi, who is the Executive Director of Medical and Clinical Affairs Administration at King Fahd Specialty Hospital, Dammam, and Maternity Children's Hospital. Dr. al-Maghribi is Consultant Pediatric Transplant and Nephrologist at King Fahd Specialty Hospital. His talk will be about guidance for health system contingency planning. So please, Dr. Muhammad.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. Thanks a lot for this big opportunities to talk about a contingency plan. It's a COVID-19 era, and everyone should be ready. We don't know about this wild virus, where we are exactly in this very tough trip. Are we in the start? Are we in the peak? Are there any further peaks that we are waiting? We don't know exactly. We know one thing, that we need to be ready as much as we can. And we know also that we are facing a very wild virus. And we know also that this is a pandemic, that every single place in the world is affected with this very wild surfaces. This wild virus didn't differentiate between advanced health system or a simple health system, but we don't know when he's coming now, it's coming to Africa, what it will do in Africa. We know only one thing, that we need to be ready as much as we can. As you see that it's not an institutional level as our title of presentation. It is regional, national, and even a global readiness plan that changed the whole world. And I will concentrate in my presentation in the regional efforts and our efforts in King Fahd Specialist Hospital for the readiness of this wild viruses. As any pandemic viruses, that you need to have a very well and good control for this virus from all aspects. This including rescuing services for the first line health professionals and other responders, and try to control the point of entry wherever the point of entry to the country or the point of entry to the institutions. Meanwhile, you need to establish a very good transportation system that take this index cases from any point of entry to a designated treatment facility that have the ability to manage and deal with this virus and control the infection with the maximum safety of the healthcare worker. So the overarching issues that controlling the whole things that you need in the regional level, public health infrastructure with the healthcare infrastructures, together with the strong communications that link all the efforts, clear out any bad ideas or false ideas or any roaming around, since there are a lot of sources of information during any crisis. During the last 6 weeks, we have thousands and millions of news here and there, and even simple people that never sit in front of any news TV or channels getting a news from everywhere. This is necessitate a huge communications methods that link the public health infrastructures and healthcare infrastructures to unite all efforts for controlling the disease. So in this regional efforts, the public health infrastructure is the most important thing. Now, I started with this level because this having a huge impact into the effect and any contingency plan of institutional level. So there is a basic issues regarding the COVID-19 surveillance, starting with case definitions, reporting form, investigations protocol. If these standardized in the regional level and in the national level, things will be okay. And if it is not standardized, there will be a huge conflict, a huge disturbance, a huge differences in managing and defining and the surveillance activities. There is also a huge need of a sustainable staffing and resources in the regional level to take over of these missions. And there is also a need of update contact points and stands operating procedures on the regional command level. Actually, in the Kingdom of Saudi Arabia, this is a very well established in the regional command centers in the level of the regional level, and central command center in the level of the national level Ministry of Health. There is a huge need of a contact tracing protocol, since there are a lot of index cases expected. So the way of tracing contact should be standardized, and there is also the pivot need of a laboratory diagnostic capabilities that include all the standard of the lab and the lab testings and the lab volume and the lab capacities in order to necessitate the needs of swabbing and surveillance duties. The remaining part of the public health infrastructures, including also clear coordination structures that including a chain of commands in public health, and also stakeholders, focal points, networks, and also training material resources standardized for COVID-19 management's infectious control practice, training logistic for point of entries of personnel, frontliner health professionals, ambulance services, and extra. Other than public health in the regional level, we need to have a very good healthcare infrastructures in two major aspects. The first aspect, designated in-country transportation system, and the second aspect is designated treatment facilities with all required resources. Now, the third major part, which is the communications in the regional levels that necessitate designated spoken persons and assess public trust in peacetime, risk communications training in peacetime for experts and stakeholders. These communications methods is the link between the infrastructures of the public health and the facilities infrastructure. Now, for the institutional level, this is the cycle of the readiness. It started with anticipations. When you have anticipating all scenario, mild case scenario and worst case scenarios, including influxes of big numbers of cases. This is identify your understanding of the problems and plan of the strategies based on your existing resources, training and capacity buildings of the institutions in all aspects and parts. Then it will go into the second phase of the cycle, which is the response. And if there is an actual clear response, when you have a true index cases, this is a very good opportunities to have an outbreak response and response of all plan and policy procedures that have been prepared during the anticipations phase. Or you can create, as what's happened in our institutions, a lot of drills in case scenarios, and also regional drills that have been conducted before 2 days. So with this response phase, you need to clarify where are the defects, what are the things that need for the recovery phase, what are the things that need to be fixed, and again, go back into a planning and strategies and building a new capacities, having a more utilizations of resources, and so on. So the contingency plan determinants for COVID-19 pandemic in the institutional level is a very important, because it will determine your exact contingency plan. One of the most important determinants is institution, infrastructure, and design. So the facility design to ensure adequate ventilation is a very important for the COVID-19, because it is an infection that may transfer from droplet to airborne in case of intubations of any procedures. Adequate ventilation is a very crucial in the institutional design. If there is an adequate ventilation or the ventilation system reveal no recycling of the exhausted air, it will be a very good opportunities to accommodate COVID-19 or even suspected cases in case of need to accommodate such cases. The number of isolation room with or without negative pressure room is a very crucial also in determining the contingency and the readiness plan. Isolated building and unit belong the facilities. It's a very important to define exactly the ability of institution, for example, to accommodate a flux of the cases of COVID positive. This is very helpful nowadays, especially in this time of the peak of the virus in our country, to dedicate a respiratory triage area in emergency or outside emergency. As much as you have units outside the main buildings, as much you can isolate and get rid of the virus outside of your main business. And this is a very crucial in your plan. I think the institutions that have a dedicated such unit outside the main buildings are very lucky institutions that it may have an asset to have a more comfortable respiratory triage area. Separate ventilation system for rooms is a very crucial in the facilities, and presence of full medical care setup for potential ICU is a huge surge capacity asset. Now, usually in the patient room, there is only two outlets for oxygen and for the suction. If you have a medical air outlet inside the regular room, this means that you may transfer all your room into a standard ICU room without any further constructions need. And this is a huge asset and a huge determinant of your contingency plan. So you need to check your facilities exactly. Are you having abilities to shift to ICU rooms with the presence of the medical air or not? The room sizes and number of beds is a very important also in the contingency plan. Other important factors in institutional determinants of the plan is the type of patient. The patient population and the type of the clinical service is a very crucial. In King Fahd Specialist Hospital, 70 to 80% of our populations are immunocompromised. This means that the infectious control measures should be on top of the top, because if the virus gets a leak to this institution, it will destroy the patient populations in no time. So the patient immunity status is a very important into getting a more strict measures. Also, patient clinical complexity have a huge impact into a capacity surge and also in maintaining clinical services. For example, if you have a simple secondary cases, the clinical services is easy, can be diverted or rescheduled in 3 or 4 months time. But if you have a type of patients that have a complex and they cannot tolerate a more time of rescheduling, this means that the burden of the primary population of the patient will be huge, and the capacity to accommodate a new populations of the contingency plan is a little and little, since you will be a burden with your complex cases. So patient medical need and demand also a very big problem, because if you have a type of population that need, for example, radiation therapy, a lot of CT, a lot of MRI follow-up, this means that the virtual services cannot be applied, because the patients need such intervention that they should be physically there. So this is affected your virtual activity. Also, regional demand of the facility of the clinical services have a huge impact on the facilities, especially if you are a unique in the region that the service cannot be, example, provided except by you. So the surge capacities, the virtual activities, and the capacity to accommodate new populations is getting less and less, because there is a need of more clinical services to be provided by this type of institution. The other determinants in the healthcare worker populations, availabilities of a critical specialist needed of COVID-19. If you have a good numbers of anesthesia, this means that you have a good capacity of running more ICU beds, even if it is in non-ICU areas. If you have, for example, a good numbers of respiratory therapists, this means that you are in a good shape into accommodating more patients of critically ill patients. Also, the training level readiness of the staff is a very, very important. The readiness of the institutions that have that know a lot of PPE, and they know exactly what are contact precautions, standard precautions, droplet precautions, airborne precautions, make a huge and big difference into dealing with such patients in a real time. When you face an institution that have no any efforts into educate and train their staff into a standard and contact and droplet precautions, you will have a huge panic and a huge redundancy into dealing with the true cases when it came and evidence on the ground. Psychological level of readiness is a very, very important. And this is actually reflecting directly the staff safety and the surge capacity of the institution. If the staff is willing, ready, and prepared psychologically to face such disaster, life will be easy for the institution to proceed with any contingency plan. Public health infrastructures and region issues are very important in the contingency plan determinants, as I mentioned before, because it's directly impacting this plan in all aspects that I described before. The COVID, one of the major also determinants, especially in the contingency plan, is the pandemic progression. As much as case penetration in the pandemic progressions, as much you need to change your bed occupancy, you change your scope of service, to change even, you may receive, even if you are not entitled as a COVID positive institution, you may attend in the tier 2, tier 3, tier 4. So you may receive a COVID positive, and this is depend exactly in the progression. This is actually posted in the regulations of the MOH, and in here the attack rate is a huge determinant of the type of the contingency of the institutions. As much penetrations and more endemic of the progressions of this pandemic, as much you need to lock down your institutions, evacuate your essential services away, get a more space for more new populations that may flood and flux from the designated hospital. Now, COVID-19 readiness plan objectives rely on the 4 major pillars. The first thing is infectious control. The second thing is maintain clinical services, as I mentioned. And the third thing is the surge capacity plan. And the fourth thing, the staff will be. The fourth corner affecting all the other 3 things. And we have a huge privilege tonight that we have Dr. Yasser Dabbagh who will speak about this staff will be in the presentations after my presentation. Now, the facility infectious control depends mainly in hierarchy of control. Since in COVID-19 we cannot eliminate it and we cannot substitute it because it's penetrates every part in the world. There is a huge space into engineering control, administrative control, and PPE. As much we go down as least effectiveness. The engineering controlling and the environmental controlling reveal and isolate people from the hazards by more isolations through engineering aspects, as I will mention later on. Administrative controls reveal change the way of people work through the administrative procedures and standards and regulations that have an obligations for the staff and for the facilities to proceed. The engineering and the administrative controls far better than the PPE, in spite that the PPE have a major role into controlling and protecting the staff. In our facilities, actually, when we start the infectious control of the facility, we start with the SIBAHI measures. These SIBAHI measures involving 4 major areas, 5 major areas: emergency, PICU, AICU, hemodialysis, isolations. Each measures have more than 20 measures, around equally between engineering and administrative measures, and all of them around the 2 PPE measures. And we obligate since more than 2 months to fulfill all the COVID-19, new COVID-19 SIBAHI upgraded from the MERS-CoV SIBAHI measures. And alhamdulillah, fortunately, we scored between 95 and 100% in the ELI of our starting in the first 2 weeks. And in the last evaluations by the infectious control from the region authorities, we score alhamdulillah 100% of all aspects of isolations and emergency AICU, BICU, hemodialysis. Again, these are control measures that give the facilities a more comfortable space into controlling the infections and protecting the staff. Anyhow, we do have a lot of measures during the last 8 weeks that rely on a lot of aspects and dimensions, including decrease hospital flow by stop visits of inpatients, limit companion stop out on past procedures, and limit OPD activity to less than 20%. We limit inpatients admission. We limit surgery just to an emergency. We try to decrease cross infections by staff cohorting in hemodialysis and in ICU. We did a lot of anti-social activity, unfortunately, like closing a recreation center, closing staff swimming pool, closing a restaurant, and we closed all the entrance of the hospital except 2 entrances, one for a regular patients and staff, and one for the emergency, with a visual triage outside in the main door and inside in the main building. We do have a mass housekeeper surveillance for all housekeepers on the daily basis in 2 points, when they exit from their housing and when they exit from their buses before entering the hospital. And we did also a mass swabbing of more than 80 swabbing of random swabbing of 80 workers. Fortunately, all 80 workers that have been swabbed are negative. We also increased the infectious awareness and education by doing a mass N95 test fittings. We have 100% compliance on the nursing. Still, we are going with the physicians. We educate more than 400 nurses in PPEs, and also we train more than 30 nurses for infectious control link nurse program as a facilitator to implement infectious control measures. So also we build some infrastructures that including a good supply of PPE, of all types of PPE for 3 months, maintenance of all hospital isolations and negative pressure rooms, fortunately just before the era of Corona, and we create 4 isolated rooms in emergency with another 4 rooms as zone 2 in emergency as a holding area for suspected cases in the emergency. We provide fumigations machines to our operations plus HEPA filter, and also all these measures try to control the infections and make our staff safe as much as possible. The other major objectives is try to maintain essential clinical services. We did a lot of measures that have a virtual activities in all parts and all aspects of the clinical services, starting from emergency, inpatients, operation room, outpatient department, and all these measures rely on one thing: to enforce the virtual services, decrease the flow of the patients, and try to prioritize the services to the most needed patients, and also try to reach the patients in areas other than the hospital, as I will describe, inshallah, in the surge capacities. The surge capacities have major issues to address it, which is the management system, because it is a very important, and this is happening through a Corona or COVID-19 management system that have a daily meetings with the CEO and the executive. Also, the facility occupancy rate according to the epidemic progressions and structural surge capacity increase, functional surge capacity increase, maximum staff utilization, and also specific COVID-19 measures to increase the capacity of our institution. In the structural capacity, we define ICU readiness plan with its related logistic and needed projects. We allocate even budget for projects that may take 4 to 6 weeks. We are now starting a big 400-meter square respiratory triage project in the emergency with allocated budget, alhamdulillah. And we have a short stay isolations room of 8 isolation room with allocated budget for it. And it's all ongoing. Hopefully, inshallah, to be ready in 6 to 8 weeks. Try to match the surge or the peak of the infections. Now, the most unique thing is the functional capacity expansion. The facility did a huge work into virtual activities, including more than 70% of the clinic through the virtual clinic. We do rescheduling of the clinic, but we do have a very good activity in creating a new outreach clinic for oncology, transplant, neuroscience in Al-Qatif and in Al-Hassa area. These activities actually now fully run by our staff who have been blocked out in that areas with a very nice patient satisfaction in a way that increasing our functional capacity. We have also facilitating outsourced patients of long-term care and some patients that can be treated in secondary hospital with the help of MOH. And also we participate in MOH telemedicine projects. We have also a lot of measures in the workforce utilization. We freeze retirement committees. We revise some of retirement staff, especially in emergency and anesthesia. We return them back to the work in order to make more readiness of for this big crisis.
We have 4 minutes, Dr. Muhammad.
Yeah, we have I'm about to finish. We have a specific COVID-19 related capacity measures, like we do an emergency isolations 3 zones. We prepare ICUs increase the capacity from 32 to 46 beds. We have, alhamdulillah, dedicated COVID-19 testing, and we started COVID-19 testing before 2 weeks. And we promote, alhamdulillah, capacity of Eastern regional lab by an expert 2 molecular biology staff. And we have also establishing a launch of COVID-19 staff swab clinic. We are running 3 big hotels quarantine fully from A to Z as a contributions in this COVID-19 crisis. And last but not the least, we do have measures that try to have a staff reassurance and staff safety. Dr. Yasser may talk in more detail about these measures. I will leave it for Dr. Yasser for the matter of time. We try to link the HR issues with the staff need, to make it as much as possible of job stabilities. In summary and in conclusions of my presentation, I think, in spite if it's that this is a very tough crisis, I think COVID-19 is a tough learner, because tough teacher. COVID-19 is a tough teacher because we learn a lot of how to be more and more ready from this crisis. I think the staff will be addressed, inshallah, by Dr. Yasser soon, inshallah, bidnillah, is the pivot and the things that you will put money on it to drive all these measures and to make as much as possible the virus controlled and as much as possible your healthcare worker safe. Thank you for listening, and thank you again to give me opportunity for this presentation.
Thank you very much, Dr. Muhammad, for comprehensive talk, and extensive work has been done by you and the team at King Fahd Specialist Hospital. It's very, very useful. Our last speaker today is Dr. Yasser Dabbagh. Dr. Yasser Dabbagh is an Executive Director, Research Center, King Khalid Medical City. Dr. Yasser Dabbagh is Consultant Child and Adolescent Psychiatrist at King Fahd Specialist Hospital. He is going to enlighten us and talk about mental health and stress during COVID-19, which is really very important topic. Everybody is needed this counseling. So please, Dr. Yasser, the floor is yours.
Thank you very much, Dr. Raida, for inviting me. Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. What we are going through right now, the COVID-19 pandemic, is a significant and major life event for most of us. You see, basically, a lot of aspects of our lives are changing. Our regular daily routines are no longer what they used to be. There's a great deal of uncertainty about the future. We are physically distancing. I prefer that over social distancing. We're physically distancing, which has a major impact on the degree to which we are in touch with loved ones, even physical touch is now avoided. There's a lot of time that is being spent at home that can strain family relationships if these family relationships have already been strained. There's a great deal of interruption of regular usual activities. There's school closures. There's a lack of physical activity. And that's not to mention the worry, the anxiety. There's worry about loved ones for people who whose jobs depend on this. There may be financial worries. There's worry about physical health, let alone mental health. And those are issues that affect everyone, not just healthcare workers. They affect us all. If any or some of these issues on their own affected a person, that would be considered a major life event. It would be considered a significant enough event that could precipitate major change in the way we think, in the way we perceive the world, precipitate or increase the likelihood of mental health issues. So when any of us goes through such a major life event, there is a great likelihood that we could regress to an earlier mode of thinking, an earlier way of understanding and perceiving the world around us and people around us. You see very young children, infants, at least from a psychoanalytic perspective, are set to perceive the world in a manner that could be termed binary, dichotomous. Things are either good or evil. They're either blissfully joyful or incredibly painful or discomforting. You're either with me or against me. Things are either going to be fantastic or a major catastrophe. You can see how that kind of binary thinking is already pervading the way we deal with this pandemic. All you have to do is look at the deluge of news that we're exposed to and material on social media. And you'll find that people can generally be categorized into an either or, one extreme or the other. Some people are dismissing this entire pandemic and saying that it's all going to wash away and we're going to go back to normal. And some are essentially saying that our usual way of life is no longer going to return. Some are discussing the pandemic from a very clinical and scientific, emotionally removed type of perspective. And others are talking about an international conspiracy or biological warfare. Now, this is happening around us, and it is something that we are exposed to, and it influences us as well. But it's also happening inside of us. It's happening between us. There is a binary way in which people used to look, for instance, at healthcare workers, particularly physicians. Prior to the pandemic, physicians were sometimes vilified. They either made too many fatal medical errors, or they earn too much that they don't deserve, or there are all sorts of ways of looking at them. But now healthcare workers are on the other extreme. People are looking at healthcare workers as heroes. The reality is both in almost every situation, both extremes coexist, in addition to a continuum that connects the two extremes. So black and white exist in the same setting, as well as a rich continuum of different shades of gray. Good and bad exist in the same person. As a healthcare worker, you could be someone who is perceived in a manner that is binary. Just because people think of you as a hero does not mean that you can't be afraid. It does not mean that you can't be worried or concerned or even hesitate to leave home in the morning to go to work. It does not mean that you're immune to the sorts of stresses that everyone else is exposed to. As a matter of fact, healthcare workers are, without pandemic, without such a major life event going on, at greater risk for stress-related conditions, anxiety, burnout, depression, acute and post-traumatic stress disorders. They're already at a greater risk for those conditions. And that didn't need a pandemic with all of these mitigation measures that are ongoing in order for them to have those conditions. So that you could assume that they're going to be at an even higher risk for those conditions. However, still the majority are able to get through pandemics and epidemics and mitigation efforts because there's a lot of them have, to begin with, good resilience. The problems that healthcare workers are exposed to are in some way similar to the problems that everyone else is exposed to. But on top of this, they have their own unique issues. But before we go on to discuss their own unique issues, I think it's really important to pay attention to some of what's happening. There is a concept called emotional contagion. So healthcare workers may be expected to be stressed, to be overwhelmed, to be overworked. Well, that is often very true, but it doesn't always, it's not always the case. And it could vary from one healthcare worker within the same institution, within the same emergency room, or within different hospitals in the same city, different towns, different regions. But overall, they are exposed to greater stress, and they're facing the brunt of this pandemic. But because there is this expectation that healthcare workers are supposed to be overwhelmed, maybe anxious and maybe depressed, some people may feel pressured to feel that way. So now this is not something that can actually be prevented. Emotions are not under our control. However, being mindful, being aware that you can be your own person is useful. There is a tendency for healthcare workers not to express emotion. They think that, during the time of stress, during a time of pandemic, when emergency rooms are flooded, there is no time to express my feelings. I have to put those aside and I have to get to the task at hand. Now, that is one of the most dangerous things that anyone could do. Suppressed emotions or repressed emotions can come back to haunt us. They can show up in our behavior when we go back home. They could show up in our mood, in the level of anxiety. We could burn out more readily. We could develop depression. We could be more prone to post-traumatic stress. It may show up in physical symptoms. We may become physically ill. We may have psychosomatic symptoms. it obviously will have an impact on our immune system. Now, the way to deal with that is that we have to recognize and acknowledge our feelings. We have to allow ourselves to go through them, experience them, and talk about them. This is absolutely essential. As a matter of fact, it is perfectly okay to be anxious. It is perfectly, whether you're a healthcare worker or not, it's perfectly okay to be anxious. It's perfectly okay to be stressed, worried. If you weren't worried, I would be concerned that maybe something is not right, given everything that's going on right now. So my advice to healthcare workers is that, I suggest you relax and let yourself be anxious. It is important to give yourself that freedom to feel what is going on around you, experience it, but just don't suppress it. Talk about it. Be mindful. Be aware of what's happening within you. Find a person, whether it's at work or at home, that you feel comfortable with, that you feel contained by, and allow yourself to get it off of your chest. Cry. Discuss what is happening in any level of detail you wish. This isn't a process of debriefing. This is a process of catharsis, a process of emotional expression. It would be great if this can also be done at work. Healthcare workers are often exposed to more stress than the general public, as everyone here would agree. But they are also given a lot more opportunity than many to be compassionate with others. Now, part of their job sometimes when there is clinical contact is to be compassionate with patients. But because they're human, they don't have an endless reservoir of compassion. They can experience compassion fatigue. If there is a high volume of patients, if the level of severity is high, if the fatality rate is high, if the complications are great, if the manpower is short, there are any number of reasons. There may be personal reasons, there may be predisposition to particular mental illness or past history of mental illness. There may be stresses in a person's life that they still have to go to work in spite of. They could experience compassion fatigue. Compassion fatigue can result in burnout, can result in increased anxiety, can result in depression. One of the things about compassion fatigue that is really remarkable is that the person who is being compassionate can have an improvement in their capacity to be compassionate if others were compassionate with that person. So if, as a healthcare worker, people around you were compassionate with you, that is likely to increase your capacity to be compassionate with the people that you care for. So what I call this is the formation of concentric circles of compassion, at the center of which there is a healthcare worker who is looking after patients at the front line, or working in quarantines, or what have you. Now that person is surrounded by coworkers, whether also frontline workers or support staff or middle management or leadership or even administrative staff, and they're compassionate with this healthcare worker. That is likely to mitigate against this healthcare worker experiencing compassion fatigue. That circle of people around this healthcare worker could also experience compassion fatigue, or they're actually being compassionate, and they have each will have their own limitation to the reservoir of compassion they can give out. Now, they need to have a circle around them that is compassionate with them, and that could be friends, neighbors, relatives. Nowadays, with the physical distancing, this could be done by phone, by video conferencing, by social media. they need people around them to be compassionate with them. That other circle of compassion needs a circle of its own. That could be the entire community. That could be society at large. Nowadays, given the positive light, the binary perspective that I was telling you about, where healthcare workers are seen as heroes, the community at large may be a little bit more kind and compassionate with healthcare workers and maybe with their families as well. And that might be helpful in establishing these concentric circles of compassion that are likely to mitigate against compassion fatigue and therefore reduce some of the potential for stress-related conditions and burnout on healthcare workers. But healthcare workers have other unique issues that they experience that very few others go through. Healthcare workers are nowadays stigmatized as a result of this pandemic. Going back home, they may have family members that don't want anything to do with them. I know healthcare workers that either elected on their own to move out of home because they were worried they were going to bring back the infection to their loved ones, or were kicked out of home by their family because family didn't want to have them near them, worrying about the contagion. I think this particular problem is uniquely hurtful and difficult for many healthcare workers. On top of this, healthcare workers can be dealing with some really difficult clinical situations. And that leads to other types of phenomena that exposes them to mental health risk. Survivor's guilt. A patient dies and the healthcare worker wonders why they were spared and didn't catch the infection. Bystander's guilt, where one member of the team is working with a critically ill patient and maybe catches the infection from that patient, while the healthcare worker, him or herself, do not catch it. And they may feel guilty for having been a bystander rather than at the front line. Or they elect to stay home and do a lot of work from home whenever that is possible. And then they feel guilty for not showing up at work when their colleagues are going through all of that. This kind of guilt is very destructive to the mental well-being of the healthcare worker. And it's understandable, but the reality of the matter is, no matter who you are as a healthcare worker, you're either going to be a survivor or a bystander. It is going to happen. And there's no avoiding any of these kinds of situations. And none of it is brought on by you. There's grief that healthcare workers go through when they lose a patient, or and that happens in normal times. Imagine what it is like these days when it may be happening at a faster pace, or because there's no visitation. So a nurse might be the one that takes on the brunt of the grief on behalf of the patient's family. This kind of situation is quite distressful for healthcare workers. Again, some of the same measures that can be helpful are necessary. It's very important to acknowledge your feelings, not to suppress them, to give yourself a time to express them, to find a colleague to talk to. Now, sometimes stress and difficult emotions, anxiety, exceed what is acceptable and lead to deterioration in functioning, lead to loss of the capacity to do the things that you normally are able to do, or a reduction in that, or loss of efficiency, or difficulty sleeping, or relational challenges and tensions at home or at work. Now, at that point, I think it would be important to pay attention to what is going on. This may not be the anxiety and stress that is acceptable for everyone. that it might have gone further than necessary. And in those cases, it might be helpful to first start with self-care and figure out what is going on internally, but then think about, if necessary, seeking help. Now, we are talking about the hospital's readiness for this pandemic, and there are things that are already in place. I mean, the hospital does have a mental health department that is available for everyone, obviously. There is an employee counseling clinic that is accessible for employees. But we've also established what's called a coping clinic. And this is a call-in clinic that presently we're working on making it 24/7 soon, inshallah. That will have its own hotline. It will be open to employees, but it will be open also to people who are living in quarantines, frontline workers of any kind. There is a project that to establish what might be referred to as the COVID Cafe, where it's a context, maybe virtual, that allows people to convene and simply talk to one another, discuss some of the aspects of the stress that they're experiencing. As I'm working at a national level in matters related to mental health, we're collaborating with the model of care teams around the country, and that will involve this hospital and the region. There's the Keep Well group that is working on preventive and proactive measures that are helpful to stay well from a mental health perspective as well as from a physical perspective. But there's also the workplace wellness programs that are being instituted. And both of these groups are going to be putting together several initiatives that could be helpful to healthcare workers. But on top of this, there's something uniquely available for healthcare workers, which is a program from the Saudi Commission for Health Specialties called DAAN, which allows healthcare workers to call in and speak to a mental health professional. And there are several levels of those mental health professionals that would reach up to a psychiatrist, and there would be consultations that could be helpful. We've made available several resources within the region as well. I know that the time allotted is short, and there are many more things that we can talk about. Issues related to families at home, children dealing with children at this time, but perhaps we'll discuss some of those during the question period.
Yeah, thank you very much, Dr. Yasser, for very comprehensive and thorough talk that is badly needed during this pandemic time. And I would like to thank all of the speakers today, Dr. Mohammed Al-Bishir, Dr. Mohammed Al-Maghribi, and Dr. Yasser Al-Dabbagh. It's really ختامه مسك. We have some questions that some we received to discuss during this evening. There is a question for Dr. Mohammed Al-Maghribi. If there is any guidelines for the staff to use mask, either surgical or N95 mask at King Fahd Specialist Hospital, Dammam? You can, Dr. Mohammed, can you unmute yourself?
The use of PPE actually in this crisis is a very crucial all over the world, because there is a huge balance. There is a need of huge balance between utilizing the right PPE in a wise way and saving the logistic supply of the PPE in the future. All of us see a lot of videos of using inappropriate PPEs in different advanced health system in different countries. And even we saw videos of a healthcare worker are obligated to do a work with the, far less than recommended of PPE because of the shortage of the supply. Now, the shortage of the supply have two issues. Either you have no budget to afford it, this is unlikely in many countries. And the major problem is no factory or no supply chain supplier inside the country, together with this crisis that, you know, that there are a lot of international borders have been cut it, and there is issue of transportations and export and import. Now, as back to your questions, it should be standardized PPE use to have a wise use that cause the protections, and without a panic use that lead to a huge utilization of the PPEs. Based on this, we are following mainly wiqaya recommendation for the surgical mask and N95 and all the PPEs. And we adopted, alhamdulillah, our contingency plan for the last 4 weeks that have mainly resource from wiqaya with an updated version every week. Every staff should protect themselves, and we adopt recently this week actually the mass surgical mask use in the clinical area. It's obligatory for every staff to have a surgical mask when they go into a clinical area. It's preferred when it came into the nurse station and inside the corridor. It is not recommended when it is outside the corridor. And we adopted extra precautions for N95 in the ICU based in wiqaya, because it is related only to airborne generating or aerosol generating procedures. But since, especially the nurses, we do have a very complex cases and there are a lot of suctioning and a lot of viral shedding in the room, we recommend every staff going inside ICU room should have an N95. It's very accessible from anywhere in the hospital, and I think it is a must to have the balance between reserving the logistic supply and protecting our healthcare workers.
Yeah, thank you for this explanation, Dr. Muhammad. A question for Dr. Muhammad Al-Bishir. What do you think if COVID-19 pandemic resolve? Is the e-learning going to continue or not? Dr. Muhammad Al-Bishir, maybe if you please unmute yourself so we can hear you.
Do you hear me now?
Yes.
Thank you for this question. What I can say is the present COVID pandemic will certainly cause a permanent and a positive expansion of e-learning. However, I cannot predict the extent of it, but I think the expansion of e-learning post-COVID-19 would probably be substantial. That's my thought.
What do you think the challenges of e-learning at the level of King Fahd Specialist Hospital or even at national level?
It's just with the support of the government, with the mission of digital transformation and e-learning, and I think with the current pandemic situation, I think all challenges has to be dissolved. The most challenging aspect is just having the people to accept adopting e-learning. We have the infrastructure, we have the lifelong learner, we have an amazing teachers, and we do have a good infrastructure with regard to IT. So I think the way now, or the challenges for the enterprise personnel to work hard on making the advancements that is necessary to make the application of e-learning more affordable and more accessible.
Is it more expensive than usual learning? The e-learning is more costly?
No, I think it's probably, you think about it, going to a conference, there's a cost of travel, there's a cost of accommodation, there's a cost of renting the place. So this is the e-learning, this just a click of a button in your place, at your home, no travel, no accommodation. So it's definitely less costly and environmental friendly as well.
Yeah. Thank you very much, Dr. Muhammad. There is a question for Dr. Yasser. What would be your advice for mothers who are staying home and they are overwhelmed with their children who stopped going to school during the pandemic of COVID-19?
Yeah, that's an important question. The reality is that children are part of this community as well, and they're exposed to what everyone else is exposed to. Regardless of their age, they will become anxious. Very, very young children are likely to be anxious as well. But if they're school age or adolescents and they're staying at home instead of going to school, they'll be exposed to a great deal of the news media. One thing to make sure is done at home is to manage access to the news media, not to hide the information, but to make sure that there is a meaningful and limited amount of exposure to the news media, and be able to discuss it, manage it, ensure that the information is understood correctly, and do that as a family. The other thing that is helpful to do is to deal with the fact that these children are staying at home, not physically active, having to do maybe school through virtual platforms, e-learning, having to communicate with friends through virtual processes. It is very important to establish a new routine for children at home that allows parents to direct children to the correct type of activity throughout the day. It would be very helpful to have some degree of management of the exposure to screens, if that is possible. During this pandemic, the exposure to screens is going to be increased, but it's also important to include in that routine some physical activity that could be done at home. It's very important to attempt to involve children in this, the development of such routine, and to modify it from time to time. Boredom is going to set in after a while. So there needs to be family meetings that design new routines going forward. In addition to this, there ought to be some rituals that they all go through, where the parent becomes the role model for the child, in order to reduce the likelihood of this pandemic having an emotional impact on children. The parent needs to role model the expression of feelings. There need to, part of the routine could be putting aside a time to talk about what the worries are, what feelings are. It would be important to role model connecting to family, especially those that we are separated from because of the physical distancing and mitigation measures. If the parent is role modeling this, and enabling the child to participate, I think that would be very helpful. Maintaining important relationships for those children is absolutely essential.
Yeah, thank you, Dr. Yasser. The last question for Dr. Muhammad Al-Maghribi. Do you think that we are ready if COVID-19 crisis happen at this time? hopefully it will not happen, inshallah. Could you please unmute yourself, Dr. Muhammad?
It's happening already. We are in the middle of the crisis, actually. I think the readiness have all the dimensions. We are ready. As a country, we are ready. As a region, we are ready. As an institution, we are ready. But all these readiness have a limit. Again, it's a wild virus. We don't know what's happening. When President Trump, before 5 weeks, said that if US reached to 20,000 deaths, we will be okay. I was laughing at that time, and they said that this guy is a crazy. Now it is a 45,000, and we don't know where it's going. So really, if the R0 remaining as it is, we started from 1.1, 1.2, we are reaching now to 2.2, 2.3. If it is starting to plateauing to at this level and not exceeding maximum of 3, we are ready. We don't know what's happening if it is exceeding 3, because in US, in Spain, in Italy, it's reaching above 6 even. And at that time, I don't think that any health system with this huge contagious level of virus can stand up for this readiness. Now, I think a lot of precautions and measures that have been done by the government, alhamdulillah, and thanks God for that, make the things are in a very nice plateauing. We have, alhamdulillah, a very nice indicator that we may not even, inshallah, exceeding 3. Number one, we do have a still limiting number all over the kingdom of ICU patients, and the morbidities of the virus in Saudi Arabia still not reaching to that level. Number two, we have, in spite of this increasing number, these numbers are numbers that have been discovered at their home. It is not a case that came to our emergency. It is not a case that, and I was observing the first 500 positive cases in the Eastern Province. Most of them came from quarantine, and that one we are the one who discovered this. Now more than 96, 97 of these cases either have a very mild symptom or even asymptomatic. But hopefully we will not reach to that level of infectivities and this viral penetration in our communities. If we remain R0 less than 3, we will be okay, and I think we are ready for that, inshallah.
Thank you so much. Really, I would like to thank all of the speakers today for their comprehensive talk and excellent discussion. I would leave the microphone to my colleague, Dr. Muhammad Al-Bashir, who is the Executive Director of Academic Affairs and Training, to give the closing remarks for this meeting, COVID-19 readiness. So please, Dr. Muhammad. Could you please, Dr. Muhammad, to unmute yourself?
Yeah, we always forget to unmute. Thank you very much, Dr. Raida. I have nothing to add. I just would like to sincerely thanks all our distinguished speakers. I would like to thank you personally, Dr. Raida. And I would like to thank the organizing company, Mansoub. And most importantly, I would like to thank our audience for the participation. I'm very pleased to know that for the last 3 days, probably on every day, more than 1,000 or 2,000 have already viewed our webinars, whether live or recorded. And that's the advantage of e-learning. So they can go back and view it at any time, anywhere, at their own pace. So thank you very much. I'm looking forward for further meetings, online meetings. I hope COVID situation will resolve. But one of the advantages of COVID-19 is actually the adoption and hopefully the sustainability of e-learning, inshallah. Thank you very much.
Thank you.